Pleural malignancy. Metastatic disease. Metastatic disease is the most common cause of pleural malignancy. Lung and breast cancer, gastrointestinal and genitourinary adenocarcinoma, and invasive thymoma can metastasize to the pleura. Chest wall metastasis. Axial CT image shows a heterogeneously enhancing mass invading the chest wall and adjacent pleural of the left lung. This was a case of breast cancer metastasis. Features to help differentiate malignant pleural effusions. Unexplained recurrent pleural effusions should raise suspicion for underlying malignancy regardless of associated visualized pleural nodularity. The split pleura sign is characteristic of an empyema, formed by fibrin coating both parietal and visceral pleuras resulting in ingrowth of blood vessels. Although rare, empyema can be seen in lung cancer. Features of malignant effusion include nodular pleural thickening, large or recurrent effusion without etiology, thickening of mediastinal medial pleura, multiple myeloma plasmacytoma. Osseous metastasis may have soft tissue components that are extrapleural, which may secondarily invade the pleura. Mesothelioma. Mesothelioma. Contrast-enhanced CT through the thorax, left image shows extensive nodular pleural thickening of the left hemothorax, arrows. Images through the upper abdomen show extensive soft tissue abnormality with invasion of the chest wall, arrows. Mesothelioma, indifferent patient from above, axial, left image, and coronal T1 weighted post-contrast fat-suppressed MR images demonstrate circumferential nodular thickening of the left pleura. Mesothelioma is a highly aggressive neoplasm arising from the pleura. Most cases are due to prior asbestos exposure, with a latency of greater than 20 years. The epithelial subtype is more common and has a slightly better prognosis. Sarcomatoid and mixed subtypes are more aggressive. CT of mesothelioma typically shows nodular concentric pleural thickening, often with an associated pleural effusion. The role of surgery is evolving, with the goal to resect all visible tumor. Trimodality therapy involving surgery, intraoperative heated chemotherapy, and radiation has been shown to provide benefit for a subset of patients. Fibrous tumor of the pleura (FTP). Fibrous tumor of the pleura (FTP), also known as solitary fibrous tumor, is a focal pleural mass not related to asbestos or mesothelioma. It is not mesothelial in origin. Approximately 20–30% of FTP are malignant, so all are excised. Malignant potential is determined by number of mitoses seen at pathology. FTP may be associated with hypoglycemia or hypertrophic pulmonary osteoarthropathy, although these associated conditions are uncommon, 5%. FTP may be pedunculated. A pleural-based mass that changes position is suggestive of FTP. FTP tends to have low FDG uptake on PET. Fibrous tumor of the pleura. CT topogram, left image, shows a round opacity arrow with a circumscribed medial margin and indistinct lateral margin, suggesting a pleural-based mass. CT confirms that the mass arrow is pleural-based, with a broad attachment to the pleura. Case courtesy Ritu R. Gill, MD, MPH, Brigham. Pleural effusion. Transidate. A transidative effusion is caused by systemic or local imbalances in hydrostatic and oncotic forces. Common causes include systemic low-protein states, heart failure, and nephrotic syndrome. Exudate. An exudative effusion is distinguished from a transidate by thoracentesis. There are no reliable imaging features to distinguish between transidative and exudative effusions. The presence of an exudate implies pleural disease causing increased permeability of pleural capillaries, which may be due to pneumonia with parapneumonic effusion, empyema, or tuberculous pleuritis, mesothelioma or pleural metastasis, rheumatoid arthritis or other collagen vascular diseases. Chylothorax. A chylothorax is a pleural effusion consisting of intestinal lymph, most commonly caused by iatrogenic injury, less commonly neoplastic obstruction of the thoracic duct. Chylothorax is also associated with lymphangioliomyomatosis (LAM). The thoracic duct originates at the cisterna chyli in the upper abdomen and drains into the left brachiocephalic or subclavian vein. Gastrointestinal imaging. Corey Robinson Weiss, Fiona E. The portal veins divide the superior from inferior segments, while the hepatic veins form the segmental borders in the axial plane. The middle hepatic vein divides the left segments 2 to 4 from right segments 5 to 8 lobes of the liver. Axial view. Above the portal vein. Coronal view. Each hepatic segment features its own central portal triad made up of a portal vein, hepatic artery, and bile duct, with peripheral venous drainage to the hepatic veins and ultimately the IVC. Mnemonic for remembering the segments. Superior segments, from left to right, 2, 4, 8, 7, 1 caudate. 2 doubled is 4, 4 doubled is 8, 8 minus 1 is 7. Inferior segments, from left to right, 3, 4, 5, 6. Segments 2, 3, and 4 are in the left lobe of the liver. Segments 5, 6, 7, 8 are in the right lobe of the liver. The left and right main portal veins divide the superior from the inferior segments and continue to branch superiorly and inferiorly before terminating in the center of each segment. The branching of the portal veins is variable. The most common pattern is a bifurcation into right and left main portal veins, with the right main portal vein then branching into anterior and posterior branches. Small hepatic vein tributaries mark the peripheral margins of each segment. The caudate lobe drains directly to the IVC, not into the hepatic veins. For this reason, the caudate lobe is often not affected in early cirrhosis since the direct drainage to the IVC spares the caudate from increased venous pressures due to portal hypertension. This leads to compensatory hypertrophy of the caudate lobe, which is a typical morphologic change of early cirrhosis. Similarly, direct venous drainage to the IVC allows the caudate lobe to bypass the increased hepatic venous pressures seen in Budd-Chiari syndrome. Compensatory hypertrophy of the caudate lobe may preserve liver function in these patients. The papillary process is a medial projection of the caudate lobe and can be mistaken for lymphadenopathy or even a mass, as it may appear separate from the medial process on a single axial slice. Imaging of the liver. Liver CT. A routine, contrast-enhanced abdominal CT is acquired in the portal venous phase of enhancement, obtained 70 seconds following intravenous contrast administration. In the portal venous phase, the portal veins should be fully opacified and contrast should also be seen in the hepatic veins. The liver should be homogeneously enhancing, allowing detection of attenuation alterations and/or morphologic changes of diffuse liver disease, such as hepatic steatosis and cirrhosis. As most metastatic tumors are not hypervascular, with a few notable exceptions, which will be subsequently discussed, liver metastasis can also generally be detected on the portal venous phase as hypotenuating masses. Of note, some breast cancers may rarely be isotenuating on the portal venous phase and may be more conspicuous on unenhanced cort. Most benign and malignant primary liver masses are hypervascular and thus are most conspicuous in the late arterial phase of enhancement, approximately 45 seconds. If the patient has a known hypervascular primary malignancy, both the late arterial phase and portal venous phase may be obtained for metastatic workup and restaging. If the patient has a suspected primary liver mass, such as hemangioma, focal nodular hyperplasia, hepatocellular carcinoma, a multiphase CT or MRI may be obtained, usually including a non-contrast, arterial phase, portal venous phase and delayed phase. Liver MRI. Compared to CT, MRI of the liver has superior lesion to liver contrast. MRI also does not impart ionizing radiation, allowing for dynamic post-contrast imaging in multiple phases without any penalty in radiation exposure to the patient. An and out-of phase gradient imaging allows for detection of intracytoplasmic lipid, which is seen in hepatic steatosis and may be seen within certain masses, including hepatocellular carcinoma, HCC, and adenoma. Diffusion-weighted imaging is useful for detection of metastatic lesions. MRI contrast agents. Extracellular agents pass through the intravascular system and interstitium similarly to CT contrast. Gadobutyryl Gadovist is a commonly used extracellular contrast agent that is 90% excreted through the renal system. Combined extracellular hepatobiliary agents pass through the intravascular system and interstitium similarly to CT contrast, but are partially excreted through the biliary system. Gadoxetic acid disodium, Eovist, is 50% excreted through the biliary system and 50% through the renal system. Indications for use include evaluation for metastatic lesions in focal nodular hyperplasia (FNH). Hepatobiliary contrast agent mechanism indications. Gadolinium-based combined extracellular hepatobiliary agents. Gadoxetic acid disodium, Eovist, taken up by liver in the delayed phase. 50% biliary excretion differentiating FNH and adenoma. FNH is iso to hyperintense. Hepatic metastasis uptake excludes a metastasis from non-liver primary. Gadobenate dimeglumine multihence only 5% taken up by the liver, requires 1 hour delay. Now mainly used in pelvic, cardiac and MSK imaging. Iron oxidobased. Ferromoxides are ferromoxitol particles trapped by Kupffer cells and reduce T2 relaxivity, making liver or spleen dark on T2 adjunct for detection of HCC. Liver ultrasound. Ultrasound of the liver is often used to evaluate patients with abnormal LFTs, as it can identify biliary pathology and diffuse parenchymal processes. Ultrasound is commonly used as a screening tool for HCC in high-risk patients given its relatively low cost and lack of ionizing radiation. Characterization of hepatic masses, however, requires further workup with cross-sectional imaging. Hepatic Doppler ultrasound is a valuable tool for determining abnormal blood flow to, within, or from the liver and can also be utilized to evaluate transplants and TIPS. Diffuse parenchymal liver disease. Hepatic steatosis. Non-alcoholic fatty liver disease can be divided into steatosis and steatosis with associated inflammatory activity, steatohepatitis. Overall, greater than 25% of the population is afflicted with non-alcoholic fatty liver disease (NAFLD), and approximately 5% have steatohepatitis. Ultimately, steatohepatitis may progress to cirrhosis. Common patterns of hepatic steatosis include diffuse, focal commonly seen in the gallbladder fossa and periportal spaces, geographic, and nodular. Ultrasound shows a diffuse increase in hepatic echogenicity relative to the right kidney. Normally, the liver and kidney should have the same echogenicity. Hepatic steatosis also causes increased sound attenuation, leading to poor visualization of deeper structures. Normal liver. Ultrasound of the liver and kidney shows the normal isoechoic appearance of liver relative to renal cortex. Hepatic steatosis. Ultrasound in a different patient shows diffusely increased echogenicity of the liver when compared to the renal cortex. CT shows decreased attenuation relative to the spleen. On unenhanced court, the liver should be slightly hyperattenuating relative to the spleen. The traditional teaching is that steatosis is present if the liver attenuates at least 10 Hounsfield units, Hu less than the spleen, although new work suggests that even a single Hu of relative hypotenuation compared to the spleen may represent hepatic steatosis. On contrast-enhanced CT, evaluation of hepatic steatosis is less reliable compared to unenhanced CT due to different contrast uptake rates of the liver and the spleen. However, the liver is considered diffusely hypotenuating if it attenuates at least 25 Hu less than the spleen in the portal venous phase. MRI can determine if steatosis is present and can provide a rough gauge as to its severity. An out-of-phase MRI imaging can more accurately quantify the degree of steatosis, although liver biopsy is the gold standard and best evaluates for the presence of steatohepatitis and early fibrotic change. Hepatic steatosis continued. Diffuse hepatic steatosis. In left image and out-of-phase right image, images demonstrate diffuse signal loss of the liver parenchyma on out-of-phase images. When water protons and fat protons are present in the same Mr. voxel, the fat and water signals are summed in the in-phase images and subtracted in the out-of-phase images, leading to decrease in signal hypointensity. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Variations in portal venous supply may cause geographic regions that are affected to a greater or lesser degree by fatty change. Focal fat does not have any mass effect, vessels characteristically run through it, and it tends to occur in the following typical locations and distributions. Gallbladder fossa, drained by gallbladder vein. Subcapsular, along the falciform ligament. Periportal. Focal fat may also be nodular and dispersed throughout the liver. Ultrasound would demonstrate hyperechoic lesions, which would be hypotenuating on CT and demonstrate drop in signal intensity on out-of-phase dual-phase GRE on MRI. Focal fat on MRI and ultrasound. A mass-like region in hepatic segment 4 arrows demonstrates signal loss on out-of-phase image top right relative to in-phase image top left, and has a vessel coursing through it not well seen here consistent with focal fat. Grayscale ultrasound bottom left image in a different patient shows an echogenic mass arrow in the medial left hepatic lobe. This was also found to represent focal fat. Hepatic iron overload. Regardless of the etiology, the iron-overloaded liver is hypointense on all MRI sequences relative to the paraspinal muscles as an internal control, and there is signal dropout on in-phase images. There are two pathways to excess hepatic iron accumulation, as described below. Primary hemochromatosis is the most common cause of iron overload, due to a genetic defect causing increased iron absorption through the GI tract. Excess iron is deposited in hepatocytes, not the Kupffer cells that make up the intrahepatic reticuloendothelial system or res pancreas, myocardium, skin, and joints. Excess iron in hepatocytes can cause cirrhosis. Liver and pancreas are markedly T2 hypointense and show signal dropout on in-phase images. The spleen and bone marrow are normal since the res is not involved. Treatment of primary hemochromatosis is phlebotomy. Primary hemochromatosis. Axial T2 weighted MRI demonstrates diffuse low T2 signal in the liver and pancreas with associated signal loss on in-phase imaging, not shown. Secondary hemochromatosis is usually seen in diseases that cause hemosiderosis, where excess iron accumulates within the res. This may be due to frequent blood transfusions or defective erythrocytosis. Treatment of hemosiderosis is with iron chelators, not phlebotomy. The res has a large capacity for iron. Therefore, iron stored in the res is generally not harmful and the liver is normal in morphology without cirrhosis. However, when the res becomes overwhelmed with iron, the hepatocytes begin to store the excess. Just as in primary hemochromatosis, hepatocyte iron uptake may lead to cirrhosis. MRI imaging of hemosiderosis demonstrates hypointense liver on conventional MRI sequences and signal drop on in-phase images, as in hemochromatosis. Additionally, the spleen and bone marrow will also appear hypointense due to increased iron stores throughout the entire reticuloendothelial system. The pancreas is spared. Primary equals pancreas, secondary equals spleen. In-phase MRI. Out-of-phase MRI. T2 weighted MRI. Secondary hemochromatosis. Multisequence MRI shows diffuse low T2 signal in the liver and spleen with associated signal loss on in-phase imaging compared to out-of-phase imaging, consistent with iron deposition from hemosiderosis in this patient with transfusion-dependent anemia. Amyloid. Abnormal extracellular deposition of amyloid protein in the liver can cause focal or diffuse areas of decreased attenuation on CT imaging. Wilson disease. Wilson disease causes high levels of copper to accumulate in the basal ganglia, cornea, and liver due to an autosomal recessive genetic defect. The liver may be hyperattenuating on CT with multiple nodules, eventually leading to hepatomegaly and cirrhosis. Variations in CT attenuation. Hypotenuating liver. The liver is generally considered hypotenuating if it attenuates less than the spleen on an unenhanced court. Fatty liver, hepatic steatosis, is by far the most common cause of a diffusely hypotenuating liver. Hepatic amyloid is rare and may cause either focal or diffuse hepatic hypotenuation. Hyperattenuating liver. The normal unenhanced attenuation of the liver is 30 to 60 Hu. An absolute attenuation greater than 75 Hu is considered hyperattenuating. Iron overload is by far the most common cause of a hyperattenuating liver. Medications e.g., amiodarone, gold, and methotrexate. Wilson disease, copper overload. Glycogen excess. Cirrhosis. Etiology and pathology. Cirrhosis is the replacement of functioning hepatocytes with dysfunctional fibrotic tissue, caused by repeated cycles of injury and repair. Etiologies include metabolic, alcohol, steatohepatitis, hemochromatosis, or Wilson disease, infectious, chronic hepatitis B or C, or inflammatory, primary biliary cirrhosis or primary sclerosing cholangitis. The hallmarks of cirrhosis are disorganized attempted regeneration in the form of nodules and fibrosis. 1, 2, 2, 2, 3, 4, 5, 6, 7. 4. 1. Nodular contour of the liver. 2. Segmental atrophy. Intrahepatic signs of cirrhosis. 1. Nodular contour of the liver. 2. Segmental atrophy and hypertrophy. Atrophy. Segment V, 7, 8 right lobe. Segment IV, medial. 3. Enlargement of the hilar paraportal space. 4. Expanded gallbladder fossa sign. 5. Parabiliary cysts. 6. Intrahepatic number 1F brosis. 7. Right posterior hepatic notch sign. 8. Iron deposition, not shown. Early signs of cirrhosis. One of the earliest signs of cirrhosis is expansion of the paraportal spaces. Atrophy of the medial segment of the left hepatic lobe in early cirrhosis causes increased fat anterior to the right main portal vein. Enlargement of caudate lobe is a specific sign of cirrhosis. Specifically, a caudate to right lobe size ratio of greater than 0.65 highly suggests cirrhosis. As discussed previously, the caudate drains directly to the IVC, not via the hepatic veins, which is initially protective against cirrhosis. The empty gallbladder fossa sign results when hepatic parenchyma surrounding the gallbladder is replaced with periportal fat. Secondary manifestations of cirrhosis. Portal hypertension causes splenomegaly and formation of portosystemic collaterals, varices, including recanalization of the paraumbilical vein. Gamma-Gandhi bodies are splenic microhemorrhages secondary to portal hypertension. These appear as tiny echogenic foci on US, tiny hyperattenuating foci on CORT, and tiny hypointense foci on in-phase MRI. This is discussed further later in the chapter. Gallbladder wall thickening is due to hypoalbuminemia and resultant edema. Micronodular cirrhosis causes cirrhotic nodules less than 3 mm in size and is usually associated with alcoholism. Secondary manifestations of cirrhosis continued. Macronodular cirrhosis features larger nodules greater than 3 mm separated by wide scars and fibrous septae. Macronodular cirrhosis is caused by fulminant viral hepatitis which does not uniformly affect the liver. Patient 1, left image, axial contrast enhanced CT shows cirrhotic morphology of the liver with large volume ascites and large esophageal varices, arrow. Patient 2, right image, coronal contrast enhanced CT shows splenomegaly and small gastric varices, arrows consistent with sequelae of portal hypertension. Imaging of cirrhosis. The typical appearance of cirrhosis is segmental atrophy and hypertrophy with nodular contour and parenchyma. Axial T2 weighted Mr. images show nodular contour of the liver with hypertrophy of the left lobe, atrophy of the right lobe, widened periportal space, yellow arrow, and right posterior hepatic notch sign, red arrow, in keeping with cirrhosis. This patient had a history of hepatitis C. Ultrasound appearance is a coarse, heterogeneous liver ecotexture with a nodular contour. Mr. elastography is a non-invasive technique in which the patient wears a device resting over their right hepatic lobe which transmits mechanical waves at a fixed frequency, typically 60 Hz. A phase contrast pulse sequence with motion encoding gradients is obtained to measure micron-level tissue deformation in response to the stimulus. Liver stiffness in kPa is measured by drawing ROI on the elastogram images. Sonelastography is also a non-invasive way to grade the degree of fibrosis in chronic liver disease. Subtypes include shear wave elastography and strain elastography. Malignant hepatic masses. Pathway to hepatocellular carcinoma. Large HCC with poorly D, number 1F, arrheniated cells, purple, and increased neovascularity. Regenerative nodule. Dysplastic nodule with increased size, cellularity, and atypia, blue. Focus of HCC, red, in the dysplastic nodule. Small HCC with neovascularity. In the setting of cirrhosis, hepatocellular carcinoma, HCC, is thought to develop in a sequence from regenerative nodule right-pointing arrow dysplastic nodule right-pointing arrow HCC. Regenerative and dysplastic nodules cannot be reliably differentiated on imaging. High-grade dysplastic nodules cannot be reliably differentiated from well-differentiated HCC. Regenerative nodule. A regenerative nodule is completely supplied by the portal vein and is not premalignant. A regenerative nodule should not enhance in the arterial phase. Most regenerative nodules show low signal intensity on T2 weighted images, with variable signal intensity on T1 weighted images. Rarely, a regenerative nodule may be hyperintense on T1 weighted images due to glycogen deposition. On contrast-enhanced MRI, most regenerative nodules enhance to the same, or slightly less, degree as the adjacent hepatic parenchyma. Dysplastic nodule. Unlike a regenerative nodule, a dysplastic nodule is premalignant. However, most dysplastic nodules do not demonstrate arterial phase enhancement, unless high-grade, since blood supply is still from the portal vein. Dysplastic nodules are variable in signal intensity on T1 weighted images. Most dysplastic nodules are hypointense on T2 weighted images, although high-grade dysplastic nodules may be T2 hyperintense. Contrast-enhanced MRI shows low-grade dysplastic nodules to be isoenhancing relative to liver and thus indistinguishable from regenerative nodules. High-grade dysplastic nodules can demonstrate arterial enhancement and may be indistinguishable from well-differentiated HCC. A cytorotic nodule is an iron-rich regenerative or dysplastic nodule. A cytorotic nodule is hypointense on T1 and T2 weighted images, including in-phase GRE images, and hyperattenuating on CORT. A cytorotic nodule is rarely, if ever, malignant. Hepatocellular carcinoma, HCC. HCC in a cirrhotic liver. T2 weighted top left image, and T1 weighted post-contrast late arterial phase, top right image. MRI shows a nodular external contour of the liver, consistent with cirrhosis. There is AT2 hyperintense, hypervascular mass in hepatic segment 2, arrows representing HCC. Unenhanced CT, left image, shows the mass to be isotenuating and barely perceptible, arrows. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Hepatocellular carcinoma is the most common primary liver tumor. Cirrhosis is the major risk factor for development of HCC, with other risk factors including chronic viral hepatitis, hepatitis B, and fatty liver disease. A hypervascular liver mass in a patient with cirrhosis or chronic hepatitis is HCC until proven otherwise. Alpha-fetoprotein (AFP) is elevated in approximately 75% of cases of HCC. Patients with cirrhosis or chronic viral hepatitis are regularly screened for HCC with serum alpha-fetoprotein levels and imaging, typically ultrasound or MRI. Ultrasound is not very sensitive to detect small HCC in end-stage cirrhotic livers. The aim is to detect single HCC foci measuring less than 20 mm in diameter, characterized by a better prognosis and exhibiting less than 20% risk of hematogenous spread. HCC has a variety of ultrasound appearances, therefore, a mass in a cirrhotic liver is considered HCC until proven otherwise. High Doppler flow may be present, especially at the periphery of the mass, due to arteriovenous shunting. The classic CT or MRI appearance of HCC is an encapsulated mass that enhances on arterial phase and washes out on portal venous phase with an enhancing capsule. HCC may be difficult to detect on non-contrast or portal venous phase court. On unenhanced MRI, HCC is characteristically slightly hyperintense on T2 weighted images relative to surrounding liver and may show restricted diffusion. The nodule in a nodule appearance describes an enhancing nodule within a dysplastic nodule and represents an early HCC. HCC is often locally invasive and tends to invade into the portal and hepatic veins, IVC, and bile ducts. In contrast, cholangiocarcinoma and metastasis to the liver are much less likely to do so. The portal veins should always be carefully evaluated in the presence of a hepatic mass. Internal Doppler flow or enhancement within a venous clot suggests a tumor in vein.